டேப் பண்ணி அந்த இதுக்கு போங்க மேம், பார்ட்டிசிபென்ட்ஸ் கிட்ட போங்க. பார்ட்டிசிபென்ட்ஸ் போயிட்டு உங்களோட நேம் அதுல வந்து கிளிக் பண்ணுங்க. அப்ப வந்து ரீநேம் வரும், அதுல ரீநேம் பண்ணி ஓகே கொடுத்துடுங்க.
Madam, we are live now. Shall we start?
Yes.
So, good evening, doctors and all the participants. I Sumon on behalf of Shield Healthcare, welcoming you all in another interesting session with Kanchipuram Obstetrics and Gynecology Society Monthly CME. I welcome all the dignitaries, chairpersons, and the speakers. So, let me introduce today's moderator, Dr. Lakshmi Madam. It's my honor to introduce Madam. Madam is the Consultant and Medical Director of Obstetrics and Gynecology, Mangala Multi-Speciality Hospital, Chennai. And Madam has more than 30 years of experience, and she is trained fertility specialist, and she won many prizes. Apart from that, this winner of poster presentation in psychological evaluation of infertile couples in ISAR 2018, and special interest in ultrasound and infertility. So with this short introduction, I request Madam to take over the session for further proceedings. Thank you very much, and over to you, Madam.
Thank you so much. Thank you. Good afternoon, all members. I'm just happy to be here to present our KOGS Monthly CME. It's an online program. Offline has been instead of offline in request of the members because of the weather and the hot and sunny season. We have just changed on to this online for this month. I welcome our President, Dr. Chakravarti sir, then our Secretary, Dr. Umayal Madam, and the Treasurer, Dr. Kritika, and all our members. To be, I'm happy that you all enjoyed. I'm going to enjoy this session. Just to tell about our President, Dr. Chakravarti sir, he's joined in Tamil Nadu State Service in November 91 and retired in August. He was a deputy superintendent for past 2 years in Chengalpet and retired as a dean in Chengalpet. He was working in Karpaga Vinayaga Mission and consultant for 14 years in Kalpakam Hospital, and then is a consult surgeon till today in his own hospital. Is a Lifetime Achievement Award he has got by Tamil Nadu, and also a Best Doctor Award by Ministry of Health in 2018. And is a Lions Club of Chengalpet, and in Chengai Ratna Award he has been awarded. And he started a private blood bank named as SR Blood Bank as a non-profitable venture. So we are happy to be as a president for our KOGS Society, sir.
Thank you. Thank you.
Few words. Can you just give us a few words?
Good afternoon, everybody. I'm really happy to join this webinar today. I welcome all the new members who have joined. It's very occasionally have put so many new members to this society, and we're all Umayal is active in preparing for the annual meeting on July. I wish a good luck for all cooperation from everybody to make it a fully successful. With this, I welcome everybody to the meeting. I welcome the new members. We'll have a good academic as well as cultural entertainments in our society, and all lot of social problems about women and women health care. Welcome everybody. Thank you.
Thank you. Thank you, sir. I next invite Dr. Umayal Madam, Umayal Murgesan, our sweet darling, the secretary, who has finished her MBBS from Chengalpet in 1988, and she's a gold medalist in obstetric gynecology in the final year, and she's the managing director of Sri Kumaran Specialty Hospital at Tambaram, and founder of the secretary, as I've told, for our KOGS Society, and she's a president of, and she's now a president for IMA in Tambaram, and a member of Practical Obstetric Committee of FOXY, and has special interest in laparoscopic pelvic surgeries and reproductive medicine. Ma'am, I just invite you to just give a short brief or a speech to our members.
Yes. Happy evening for everybody who has joined to attend this webinar of our society. And I thank Dr. Priyanka for logging in, and we've got an excellent speaker there to give us a lot of inputs on his topic. And I'm very, very happy with the way our KOGS team is actually growing now. Now, actually, there was a time only when I was the single person trying to do all the work. Now I have so many leaders who are just popping up from this group, and each one is trying to excel each other in their field of work. For example, the membership committee which we formed, which was formed by Kritika Devi and Vijay Lakshmi, they have actually this 1 month alone, they have brought in 11 new members, which is really a great achievement. So really, I feel very happy. Any society to become successful, we need members. And we need members who want to be a part of the society and who want to showcase their talents through this society. So increasing the membership is a very, very important part. And so I really appreciate the hard work done by our team. And next is our academic committee, which is again doing so well. And our upcoming conference is going to showcase their talents. The topics were extensively discussed by the academic team. Here, Dr. Bhuvneshwari, Dr. Padmaja, Dr. Shobhana Priya, Dr. Anit, and Jaleta and others, they have all sat together, broken their heads, got the topics in, and even the speakers, they wanted us, they were, I am overseeing the entire process, but the input was completely given by the team. And when you come and see the topics, you will be amazed. There is a big array of interesting topics for everyone. So any practitioner can come and get some information and go back. So that is how the conference is being focused. And apart from that, we are also having our own president, Shantakumari Madam, who is going to come and give our oration. Our first oration, A.R. Chakravarti's oration is going to happen this year. And it is a very special moment for all of us. So this shows that our society is really becoming bigger and it is being recognized. And we are able to create orations by our own selves. And it's a big crown. I feel I'm so proud and so happy when I'm even talking about this. And likewise, we have almost around 15 to 16 members are going to be academically active. I mean, we have involved everybody, all the members. Our society is a very small society, but we are having almost 12 to 15 doing talks and panels, and all the other members we have involved in panels, and they are going to coordinate the halls, and they are going to take care of the entire session. And so it is going to be a real feast for 2 days. So I would request every member to be a part of it and to first participate, and then to make sure that the conference goes on very smoothly, because a lot of national faculties and our state faculties are going to be there. So this one occasion, we have to make full use and show what already we are making a mark. But again, thank you. Thank you for the time given for me to express myself. Thank you so much, Uma.
Thank you, madam. Okay, now let's move on to our academical session, which is going to be chaired by Dr. R.S. Kritika Devi and Dr. Bhuvneshwari. And first, before starting, I'll just introduce our Kritika Devi, who's the smart, young, energetic, beautiful treasurer and our Perumal for our society to tell. She's our managing director for the Babu's Maternity Hospital and a treasurer, as I've told. And she's a chairperson for the Women's Doctors Wing, and district coordinator for PPLS scheme, and a coordinator for MPH. And her field of interest is high-risk obstetrics and infertility. Next, Dr. Bhuvneshwari, another young, energetic, academically oriented doctor. You can tell a member is really needed for the KOGS, who has finished her MBBS in Stanley Medical College, her DGO and Institute of in Egmore. And she's a consultant in Dharani Clinic, West Sambaram and Tamil. And she's got a 15 years experience as a private practitioner in OG. I just welcome you both, and I would like you both to start the academical session. Thank you.
Thank you, ma'am. Ma'am, Kritika, ma'am, first you introduce, ma'am.
Introduce Dr. Anit.
Yes, ma'am.
It's indeed a great honor and a pleasure to invite our young, energetic OBGYN, Dr. Anit Kumar, my darling. Dr. Anit Kumar, he graduated his MBBS from PSG He did his MSOG from Madras Medical College, and he did his diploma in reproductive medicine from Kiel, Germany, andrology certification from Cleveland Clinic, USA. He did his MSOG from UK, and he has done his fellowship in reproductive medicine at Saimar, Cochin. He's a consultant at Sri Kumaran Specialty Hospital and Fertility Center, along with my Babu's Maternity Hospital. He's a consultant, and his interests are in laparoscopic pelvic surgeries and reproductive endocrinology. And he has won so many paper presentations and quiz at various national and international conferences. Happy to welcome Dr. Anit. Over to you.
Thank you, ma'am. Thank you for this kind introduction. I'm really happy for the for the introduction that you gave. So let me just go on to my topic directly. So my topic for today is empirical therapies in obstetrics and gynecology. So this is a very interesting topic. So the topic that I really was very enlightening for me and started preparing for it. So yeah, so moving on to the topic directly without wasting any time. So what does empirical therapy actually mean? Okay, so going by the definition, empirical therapy is a medical treatment based on experience, and more specifically, therapy that is begun on a basis of a clinical educated guess with the absence of any complete or perfect information. So suppose suppose we come to a diagnosis and we think this might best work in this patient. That is what empirical therapy actually means. So the name has the same stem with empirical evidence involving the idea of a practical experience. So if it is not based on any strong foundation, then why do we prescribe them? So because we want the patient to be happy. So the patient comes, and if you do not prescribe if you send them off without prescribing any drugs, and definitely the patients will be like, what doctor is this? And finally, the patients are happy, so the doctors are also at the end of happy. That is the thing. Next, there has always been a tug of war between an experience-based treatment and an evidence-based treatment. So, so how do I say this is like various times, like so like I finished my after finishing my post-graduation and my MSCOG, I'll be like, whenever a patient walks in, so this will be the best treatment that is actually needed. This is what the guidelines say. This is what the papers say. But whenever my my mother will prescribe something of she's been doing it for the past so many years, and somehow that works. And sometimes if I try to follow what is given in the publications, or what is given in the guidelines, sometimes I have burnt my finger. The patient might land up in some unexpected complication. So yeah, so there is this young doctor. So we are medical clinicians. We are brought up and trained to study large research on a continual basis. It has become a part of a professional creed and culture also. And so we can also cite the most recent medical research and the latest thinking in the profession. But we don't know what is exactly happening in the local area, and we don't know. It takes time for us to understand what is actually happening in the local population and regional differences that occurs. And so we understand research, and we know the strengths, and also we know the limitations of research. But only a senior doctor who has a very high level of experience, can combine the academic research and also use his practical experience and the evidence-based decision to make a correct decision or identify the correct treatment for this patient. So there is always a distinction to be made about evidence-based decision making and making decisions using evidence. So this line, it is very important, and this line has it is a big difference. So making evidence-based decisions and making decisions using evidence. So that is the major crux. So we have huge number of empirical therapies. So some of the empirical therapies like in obstetrics. So we give vitamin D, calcium, iron in a patient who is not anemic. It's also type of empirical therapy. We give traffic before LSCS. Some doctors, they do believe that elective 38 weeks, or 39 weeks, that is a preterm, little bit early induction does help. All of us love our valethamate, epidocin, and our combination drugs, especially from Chengalpet Medical College. So we give lots of drugs, and IOG we used to give that. And meso, like after delivery, we give prophylactic meso, an extended dose of antibiotics for 5 days, or seropeptidase, GBS prophylaxis, antibiotics for PPRM, long-term tuberculosis, mifepristone for a long time, and cervical encerclage in patients. We feel like, okay, let us put the cervical encerclage for our safety. These are some of the empirical therapies. The list is huge, so these are some of the things that I've taken up. In gynecology, we have any patient with white discharge, we'll be happy to write a course of antibiotics or an antifungals. Patients who are on menopause, we do prescribe phytoestrogens, antispasmodics in UTI, prophylactic antibodies in UTI. In surgeries, we do keep addition barriers. Ovarian drilling had been a fad, and it is now coming up. And drains, so people keep drains so that they just sleep better in the night. And as a surgeon, a gynecological surgeon, we do have an extra stitch. Each of them has an extra stitch, so that we are all comfortable with it. Infertility, there is huge number of prophylactic treatments there, because only like majority of that are yet to be proved whether it actually works or not. So it goes from preconception, Ecospirant, myoinositol, steroids, your GCF, growth hormone, PRP, microfluidics, PGTA. Everything is almost in a it leans towards empirical therapies, because the evidence is more and more against them nowadays. So since it is a very short 20 minutes talk, I've taken up just 4 topics. First topic is myoinositol. Does it help? So myoinositol is is an inositol. So inositol is found all over our body. It doesn't. So myoinositol doesn't only help in the in our reproductive system. It has roles various like cell survival, growth, central nervous system, the osteogenesis, metabolism, reproduction, and the mood of the patients. So in PCOS, one of the major pathologies is hyperinsulinemia, which can lead to hyperandrogenemia and oligoionization, which can finally cause PCOS. So not going into the detailed mechanism of myoinositol, but myoinositol, is tend to reduce the adipose tissue and increase the sugar uptake in these adipose tissue and muscles. So it increases the sugar uptake, so it decreases the insulin resistance, and it acts on the theca cells of the of the ovaries and reduces the androgen production as such. So PCOS has high insulin. Inositol improves insulin sensitivity and reduces the blood glucose. PCO is found to have lower inositol and can improve ovulation, and minimum it need to take for 3 months to have effect. This is a very interesting picture which I found in one of the research papers. So this is a ovarian follicle with the myoinositol. So the ratio of myoinositol is between 100 to 1 in a normal patient, but in a patient with PCOS, the ratio of myoinositol is very less. That is why basis form of the idea of giving myoinositol to PCOS patient. So if you talk to an endocrinologist, they'll be like, myoinositol doesn't work. But being gynecologist, we have seen myoinositol working day in and day out. So we are very comfortable with prescribing myoinositol. And there is a 500-fold reduction in the amount of myoinositol when compared to the normal and the PCOS ovaries. So the protocol for effective management of PCOS should be based on the PMA at the end of the day. When prescribing myoinositol, these are the 4 pillars that needs to be remembered. So first is the ratio. So the ratio of myoinositol in the tablet should be around 40:1. The compliance is important because the patient has to take daily for some time, or at least 3 or more months. So the taste and acceptability should be there. It has been proven that more than tablets and capsule powder form is more effective, and the dose is about 4 grams per day. So it is given as can be 2 grams BD, or if 4 grams sachets are available, you can give us 4 grams per day. That is my take on myoinositol. Then moving on to preconception, aspirin, and infertility. So what do we know about aspirin? So first of all, we are recognizing that inflammation as a major contributing factor for reproductive dysfunction, and we already know that low dose aspirin is used in MI patients and atherosclerotic patients, especially used in cardiology a lot because its role is proven. And we have now started prescribing low dose aspirin from 12 weeks of gestational age to reduce the risk of preeclampsia. So what about giving Ecospirant as a preconceptional drug along with folic acid? Yeah, so in infertility couples. So the cause of pregnancy loss and nuclear pregnancy is unknown in majority of the cases. So if even RPL patients, we can't find up to 50% of the causes. So excessive inflammation has been known and it has been proven to be a major cause of infertility, especially in poor oocyte quality, pelvic inflammatory disease, PCOS, and endometriosis. The aspirin, through the modulation of excessive of inflammation, reduces the implantation and improves implantation rates. And the aspirin has the ability to increase the blood flow to the reproductive organs. And third most important is aspirin is very low cost. It is hardly a few paisa per tablet, and it has relatively few side effects, and it's widely acceptable. So this has been a landmark trial. This is the eager trial. The effects of aspirin in gestation and reproduction. This is a story of it is dubbed as a story of discovery, actually. So, and it has been first published in Lancet, and various other papers have been done. So in this study, basically it has compared infertile couples of more than 1 year giving low dose aspirin with folic acid and a placebo plus folic acid. It has been shown that low dose aspirin does improve spontaneous conception in pregnancy, and it helps to continue women with history of pregnancy loss. The timing of medication is very important. This has been in all the other trials. Aspirin has been started after becoming pregnant. This is the first trial where aspirin was started, before your pregnancy has actually started. And second, so the subsequent studies have been done with measuring the highly sensitive CRP levels. So it has been found that women with increased CRP levels actually benefit when giving aspirin. And yeah. And advantages is it is a relatively inexpensive drug. It modulates the inflammatory markers and helps in embryo getting implanted. In conclusion, the findings of eager trial date has been initiated. Many new pathways for clinical discovery in women's reproductive health. So, but are we justified in giving it as a routine preconception pill for all patients? First of all, it can cause some side effects, especially GI side effects, nausea, vomiting, allergic reactions. So it has been found that patients who have had aspirin preconception, they have an increased risk of vaginal bleeding like spotting or subchorionic hemorrhage. It has been found to be figurant, but there has been no increased risk of abortion rates have been found, and there is no increased risk of any abruption that has been found. So basically, it is a relatively safer drug which can be used. When spotting comes, it needs to be stopped for a few days. That is what we have been found. We have been seeing it on routine clinical practice. Another biggest concern is your US FDA and an Australian drug category as given as category C and not assigned. So basically, there is no data on whether it causes any anomalies or not. But we have been given aspirin for so long time, and we have not seen any anomalies due to aspirin. So the risk is also negligible in this case. Moving on to tranexamic acid in cesarean section. So yeah, so when I was doing my PG, so it used to be a routine practice in our clinical this thing to give tranexamic acid, during taking a previous LSCS or a primary section, because tranexamic acid reduces risk of blood loss. So tranexamic acid, we know that it has now been proven beyond doubt that it reduces blood loss and decreases the incidence of PPH. So another interesting is that I've known a few doctors who use topical tranexamic acid. So whenever there you open up a cesarean section, when there is like certain spots we need to take a bite, and it doesn't keep on oozing at certain points, and you're hesitant to take a bite in that area. So I've seen a few of my seniors or my professors, putting topical, just pour the tranexamic acid over the bleeding spot, and it does seem to be work. So, and it got me thinking whether is there any data towards that. So, this study was done in the US. A clinical trial has been initiated where they actually did this, put 2 grams of tranexamic acid in 500 ml of NS and put it as a drip irrigation. So throughout the cesarean section, one person was, dropping the tranexamic acid with this thing. So it has been found that the topical tranexamic acid works as good as an IV tranexamic acid. So yeah, so some of my seniors were correct in using a topical tranexamic acid also. But the biggest concern of using tranexamic acid is this WHO and FDA have recently given us a warning. So because especially the medication errors with Tranexamic acid resulting in an redundant intrathecal injection. So we have all heard, or we might have heard, anecdotal stories passing from senior to junior, where there has been a misplaced drug of Tranexamic acid injected into the spinal cord, and bad complications or morbidity has been and mortality has also been resulted. That is because the Tranexamic acid and your bupivacaine vials do look the same. They look like twins. This is your Tranexamic acid that we see in a normal government hospital in Tamil Nadu, and this is Tranexamic acid and the bupivacaine vial. So when you're in a hurry to give a spinal law and there is like 5-6 cases in line, this could be easily mistaken for. And this is a bupivacaine and a Tranexamic acid which you get in the private setup. So this is such a similar looking drugs, and we should be very careful, or we should like take proper precautions in the anesthesia side to make sure it doesn't happen. But the last topic is phytoestrogen and role in menopause. So yeah, so does it have an effect? So 80%. So many women do require hormone replacement therapy. So they do suffer from all their menopausal symptoms, and majority, about 80%, are not willing to take any drugs for the symptoms as such. And we are very happy to give of the phytoestrogen tablets for them. So yeah, please try this drug. So I know Shield is sponsoring this talk, but yeah. So, but the term phytoestrogen is generally taken up from hundreds of food, taking from isoflavones, ligands, and coumastones. So usually what happens is phytoestrogen goes into your intestine and it gets metabolized into drugs with pockets of estrogen receptors. So there are two types of phytoestrogen that are commonly available. One is from the soy, where you get the isoflavones, and the other type of group of isoflavones which you get from the red clovers. So initial studies did find out that phytoestrogens were responsible for did help in menopausal symptoms and did increase cardiovascular studies. But one important thing that we need to know is this soy is a very allergic drug. So it can cause allergy in quite a lot of people. So you need to be very careful in prescribing soy-based drugs to the general population. And my take on this is, why do you take a pick lock when you have the original key present? So we do have a wide range of estrogen compounds available. So why not use actual estrogens then relying on a phytoestrogens for menopausal hormone treatment? Yeah. And so what does the Cochrane library say about use of phytoestrogen for menopause symptoms? Cochrane did find out that it didn't have much of effect when compared to placebo phytoestrogens. So as per Cochrane, it doesn't work much. Yeah. And another thing is that a lot of commercial available phytoestrogens, we don't know what are the components of the drug, and it could vary from unspecified nature and concentration. Sometimes this could have an physiological pathophysiology that we might not know. So the concept of phytoestrogen being natural and safe, is quite a doubt, and we need to use you could use your physiological estrogens in phytoestrogen as such. Yeah. So thank you. This is my talk.
Thank you, Dr. Anit. Actually, we won't have much evidence for all the talks you have given. So whoever the manufacturer of the drug should make us do some trials so that they have some evidence on it. Actually, yours is a very good topic to be discussed, but unfortunately, because of lack of time, you stopped with 4 important things we use in our clinical practice. All controversial and debatable medical and surgical procedures are empirical. There is nothing like we have evidence for it, and every doctor, not only the gynecologist, would have used an empirical treatment, including you, we have evidence for everything. It's a good talk, and I appreciate your patience in finding out some evidence for the empirical treatment. But we have to make the empirical treatment more evidence-based. That should be the ultimate aim for this talk. Even the Shield people, while promoting their product, they can even promote some research or papers asking the doctors to give some evidence on what they find out. They are more doing on this marketing side than this research side. Probably we are not aware of what they are doing. But you have done a very good work on the empirical talk. Congratulations. Ma'am Kritika Devi, ma'am, any comments?
Hello.
Unmute.
Unmute. Ma'am, unmute, ma'am. Kritika, ma'am, unmute pannu.
It was indeed he has taken a lot of efforts, including this tranexamic acid. It was very wonderful because tranexamic acid I didn't know. Let me also try this empirical tranexamic topical tranexamic acid in my practice from tomorrow. I'm thinking empirical. If we start doing evidence based practice, then there's no question of this empirical and all. Let me also try this tranexamic acid, and then probably next CME we can talk about this in person. Anit, very good talk. I really appreciate his efforts.
Thank you, ma'am. Thank you. Thank you. Comments.
Can we move on to the next speaker? Priyanka is ready.
Let me introduce Dr. Priyanka Roy. He's a consultant and infertility gynec endoscopist from Siliguri. He's a consultant in Nova IVF and Roy Clinic. He has a wide profile to be seen and to be proud of. Actually, I was going through his profile and was telling Anit that he's very good, and you should also come up to this level, and I want you to see in this position. Welcome, Dr. Priyanka. He is an Indian representative of WATOG FIGO, National Coordinator, Perinatology Committee, FOXY, East Zone Coordinator, Infertility and Endocrinology Committee, FOXY. He is a Joint Secretary of Siliguri OBG Society, Organizing Secretary of FIGO FOXY East Zone in 2020. He has published over 60 articles and authored 15 chapters. He is peer reviewer of various journals and presented 50 articles in various conferences. He has many awards to this to crown him. He's a gold medalist, and he's also a FOXY Research Awards, Fellowship, so many awards. Welcome, Dr. Priyanka Roy, for our KOGS Monthly CME. And he is also a speaker in our annual conference. So it is an introduction to him to our society, and we cordially welcome to this CME, sir.
Good evening, ma'am. Respected chairpersons, respected Chakravarti sir, Umayal ma'am, Kritika ma'am, and all the office bearers of the Kanchipuram OBGYN Society. It's indeed a matter of pleasure for me to be among all of you today on this virtual platform. And as ma'am has already said, thanks for extending the invitation for the physical CME as well, physical conference as well in the month of July, and I'm really looking forward to that. So with your permission of the chairpersons, I'll go ahead with my talk on WHO guidelines for intrapartum care. So Professor Muhammad Fathallah, who was a FIGO president from 1994 to 97, once stated, women have a human right to go safely through the risky journey of pregnancy and childbirth, a right that should be respected, protected, and implemented. In 2008, in 2018, WHO came up with guidelines, with intrapartum care guidelines, the aim of which was to improve the quality of essential intrapartum care with the ultimate goal of improving maternal, fetal, and newborn outcomes.
Sir,
From labor onset through...
sorry to interrupt. Your slides are not moving, sir. Only the first slide is visible.
Slides are not moving?
No, sir.
I just once more share my screen. Sorry.
Okay, okay, sir.
Now it is.
Yes.
Sir, when you go into full screen,
is it moving now?
When you go into full screen, it is not moving, sir. Actually,
it's not moving now. Also,
no, sir. When you go into full screen mode, it is not. It doesn't work. Yeah, now it is moving, sir.
Is it moving now? Going to the next slide?
Yeah, now it is.
Yes, sir. Yes.
Then I'll do it this way only, no?
Yeah, sir. This is very clear, sir.
I'm so sorry. I think you can see it smaller, but then
it's fine, sir.
Just one last try. If you see, if it's in the full screen, it is moving.
Full screen is not moving, sir. They are moving.
That's, I don't know why. Okay. Sure. I'll present it this way then.
Yes, sir.
Yeah. So 2018, WHO intrapartum care recommended to improve the quality of essential intrapartum care by improving the healthcare setting and it is also for the healthy women and the babies, and from labor onset through to the immediate postnatal period. Yeah. So respect. It's moving now, right, Anit?
It is moving, sir.
Yeah,
yes.
perfect. Thank you.
Yes, sir.
So respectful maternity care is a thing that has really come in nowadays, and we definitely need to respect our patients. We need to respect their dignity, and also we need to respect their choices. We have to understand that we have to make childbirth a memorable experience for the woman, for every mother, because they should feel valued, respected, and cared for. We also know that Foxy as well as FIGO has come up with respectful maternity care in a big way. Empower and inform the woman, take her permission for conducting medical procedures and even for examinations. During examination, be gentle, comforting, and reassuring. It's so very important for us to just pull up curtain. You will see the sort of difference that it makes for a patient when you provide curtains and screens for examination and not leave them without a screen when you're examining them. It's so it gives them so much of dignified feel when you do just that small step, and you need to keep her records and all the details confidential. Allow a companion of choice to every woman through labor and birth. And also, all women are equal. I have heard in many places where people talk about this patient is an ESI patient or this patient is an Ayushman Bharat patient, and not give probably the equal amount of care that is required for them. So give them the respectful care regardless of ethnic background, culture, social standing, educational level, or of their economic status. So what are the guiding principles of WHO intrapartum care model? Labor and childbirth should be individualized and woman-centered. No intervention should be implemented without a clear medical indication. Only interventions that serve an immediate purpose and proven to be beneficial should be promoted. A clear objective that a positive childbirth experience for a woman, the newborn, and her family should be at the forefront of labor and childbirth care at all times. Humanization of childbirth. In 2000, International Conference on the Humanization of Childbirth, Brazil defined humanization and humanized care during labor and childbirth. USAID in 2010 commissioned the Bowser and Hill landscape analysis of disrespect and abuse In 2011, it was White Ribbon Alliance leads development of respectful maternity care, the universal rights of childbearing women. And that's when this concept of respectful respectful birth or respectful abortion or respectful care through maternity came up in 2011 for the first time. In 2014, WHO statement on disrespect and abuse calls for research and action, names respectful care as an essential component of quality. In 2015, WHO publishes updated systematic review and proposes new typology of mistreatment of women during childbirth. So respectful intrapartum care talks about the respect for beliefs, traditions, and culture, empowerment of the woman and her family to become active participants in healthcare. Now, we just imagine a situation. We know that in southern India, in few places, or some places in Rajasthan, where the grandparents want to feed some bit of honey to the child. Now, if that is something that you do not allow, then I would say, I know it's medically not very sound, medically it doesn't go by what the rules or what the laws say, but then we definitely need to respect that bit of sentiment of the family, respect that care that the patient requires, and go through the same, because that will give that bit of extra good feeling, extra dignified feeling for the patient and her families. We need to promise continuous support during labor and also promise a companion during labor and birth, the right to information and privacy, and freedom of movement during labor. Humans are not bonded. Humans do not need to be bonded to their bed, do not need to be bonded to whatever situation you may say in labor. People, women can move about, can take the position that they find comfortable. And you know, in today's day, there are various different positions which are again coming back, which we used to see in our textbooks as historical figures have come back again, and people can deliver in those situations as well. There's Dr. Professor Frank Lewin from Germany, who is nowadays even talking about four-limb position, and he says the four-limb position is very vital in helping in delivering a woman vaginally. He is also advocating breech. There's some trial called a term breech trial, in which is advocating breech delivery for women in a four-limb position, that is 2 elbow and 2 knee position, and allow the breech just to come down on its own, and it just delivers on its own, which was a beautiful deliberation that he recently gave in Salem as well. And I'm lucky to be part of his term breech trial team, and I have been doing a lot of programs with the term breech trial, and we have done a workshop in Figo, and recently going to do a workshop in Kuala Lumpur in Malaysia as well as part of his team. Now, choice of position during birth, as I've already talked about, good communication between client and provider. Now, the client here is the woman and provider is ourselves, because in today's day, I think we have come to the situation where whenever the patient used to call us that you are God, we need to definitely tell them we are not God and we are just doctors, because we are here to help you through your process, and we cannot justify, we cannot rather, you know, we cannot deliver to you what you exactly want, because that only God can do. We can only try and help you out in your process. We can try and save you, but we cannot say 100% guarantee that we will be able to do what we intend to do. Support of the mother-baby pair, improvement of working conditions and respectful and collaborative relationships among all cadres of health workers, prevention of disrespect and abuse and institutional violence against women, which I'm sure in South India is not much. Restricted use of episiotomy objectives and design. Now, when we talk about this, I don't know whether it's a routine practice for you to practice episiotomy, or rather I should ask another question on a prior basis to this question. If you do practice a lot of vaginal deliveries is another thing that I need to talk about, because there has been situations in few of the private hospitals where vaginal deliveries are not much and there's more of cesarean sections that are happening. So first of all, vaginal deliveries. Second question is, what is your opinion about the restricted use of episiotomy and the objectives and its design? So this was a study that was published by WHO in 2018, and the objective of the study was to evaluate the possible benefits, risks, and costs of restricted use of episiotomy versus routine episiotomy. It was a meta-analysis of 6 randomized controlled trials, and the implications was clear evidence to restrict use of episiotomy in normal labor. So, in this while talking about the episiotomy study, during my postgraduate days, I had done a study in JSS Mysore where I had studied about the episiotomy and routine vaginal and routine tear in comparison to episiotomy. And the study, which was published in our prestigious Joki journal, proved or went on to say that episiotomy is not required in all women. If we give a good perineal support, we can do away with only probably a first or a second degree perineal tear, and even a baby of 4.3 kg can come out with only a first degree perineal tear if only the support is good. Remember, please do not stretch the perineum. We have this habit of stretching the perineum, applying a lot of jelly to it, thinking that the head will just slide through. But the head will not slide through. Head is not something that can just slide through. It has to come to that position. It has to descend to that level of +2, +3, or +3, +4, and +5, whichever station you follow, -3 to +3 or -5 to +5. So it has to come to that station and then it has to come out. So you'll have to give her that time, you'll have to wait for that time, and then only it has to come down. Remember, once you have dilatation of the anal sphincters, that is when you know that she has gone into real second stage. That is when you know that she has come into the expulsive phase of the second stage, and that is when probably you'll have to go there. So you'll have to encourage the patient, and at the time of the extension of the head, that is when she requires support for prevention of tear into the third degree perineal tear into the anal sphincter or the anal mucosa and the anal musculature. Now, infection prevention is a primary practice when we talk about respectful maternity care. Infection accounts for almost 14.9% of all maternal deaths. These deaths can be avoided with infection prevention practices. Use disposable materials, which I'm sure all of us do now. Decontaminate usable materials to labor and childbirth. Wear gloves during vaginal examination, during birth of newborn, and when handling the placenta. Wash hands, wash woman's perineum with soap and water. Ensure that surface on which newborn is delivered is kept clean. On addition to all these things, I would also go on to say one more important thing. Shaving is now out of the practice. Please do not go and shave the perineum, which leads to small cuts over there, which can get infected later on and can be disastrous for the patient. Second important thing is, even enema is now out of practice. Do not practice enema. Do not put in hot water into the rectum. Do not put in all that things. Hot water on the perineum can lead to scalds, which can later on lead to infections and can be disastrous for the patients. So do not do things which are not medically proven, which will not help the patient in any way. Just do things that you feel will be helpful for the patient, and that too which is backed up by guidelines from WHO, FIGO, as well as FOXI. Now, high-level disinfect instruments, gauze and ties for cutting the cord can definitely be used and is very, very essential. Partogram, I'm very sure all of you use it. The partogram and its criteria for active labor. I will not talk about this much because we have now come into the WHO labor care guide, which we are primarily here to talk about. So for partogram, we knew that there was an alert line and an action line. The alert line started from active phase of labor, which was 4 centimeters at that point of time, and now it has slowly shifted to 5 centimeter and in the process of now getting shifted into 6 centimeter, because now according to the recent definition, it's when a lady is on 5 centimeter dilatation is only when we call a lady in active stage of labor, and the lady is 6 centimeter dilated. That's when you're supposed to shift that lady from a first stage holding area to the labor room for facilitation of delivery further on. So the partogram previously had 4 centimeter and 4 centimeter apart was the action line, on crossing which we had to take some bit of action, which is now gone, and which talk about the labor care guide in this presentation subsequently. Now, what are the best practices for third stage of labor? Active management of third stage of labor, oxytocin administration, controlled contraction, uterine massage after delivery of the placenta to keep the uterus contracted. There are a couple of modifications that has come from WHO now. In addition to the oxytocin, you can add carbitocin if you feel that drug is warranted or you feel that it's quite safe to use in that patient. Second addition that has come in is tranexamic acid, which can be administered in addition to oxytocin or carbitocin. Remember, in a vaginal delivery, tranexamic acid is usually administered half an hour prior to the procedure, and in a cesarean section, it is 1 hour prior to the procedure for maximum effect and maximum action to prevent PPH and also to cut short the third stage of labor. Secondly, controlled contraction during a vaginal delivery is only to be followed when a lady is delivered by a trained health professional. Do not practice controlled contraction when it's not a trained health professional, because that can lead to uterine inversion, which is a disastrous thing for the lady again. Uterine massage is something that we definitely need to follow, and I'm very sure the oxytocin administration, all of you do it now after the delivery of the baby within 1 to 3 minutes, and not at the delivery of the anterior shoulder as it was practiced before. Routine examination of the placenta and the membrane. I'm sure you do it, but I'm also very sure that some of you don't do it because just in the last week, I had a meeting where I just routinely said that I'm very sure you do it, and then I asked, I'm sure you guys do it, and there were only 10 hands that came up and another 10 didn't come up. So that goes on to say that it's not a routine practice, but please do practice it, because 22% of maternal deaths are caused due to retained placenta, primary and the secondary PPH, which can be disastrous for the lady if she stays really away from the hospital. Routine examination of the vagina and the perineum for lacerations and injury, and especially if there is any hematoma that is forming, that needs to be diagnosed, that needs to be evacuated, and that needs to be ligated and treated at the earliest to decrease the chances of morbidity and mortality for the patient. This was a study that I had done when I was doing my post-graduation, again published in a Jogi journal regarding tranexamic acid. And tranexamic acid, as I mentioned, went a long way in decreasing the chance of PPH for this patient. This has also come in the WHO recommendations for prevention and treatment of postpartum hemorrhage. And this is said to be given in concurrence with oxytocin or carbitocin as part of the third stage of management practice. Now, labor and childbirth use non-invasive, non-pharmacological method of pain relief during labor, which includes massage, relaxation techniques. And I had given a talk in Chennai, OBGYN Society, in their annual conference about water birth. Water birth is now talked about, and it's one of the methods for pain relief. Lukewarm water is said to relax the muscles of the perineum and decrease the pain as well, and also facilitate the delivery of the baby. Offer oral fluids throughout the labor and childbirth. And please, do not abuse the lady, do not slap her, do not pull her hair, trying to make her push and all that. Please do not do things like that. You can be gentle with her. Believe me, she'll deliver. If she has to deliver, she'll deliver vaginally at her own pace without any much of complication. The only thing that we need to do, I also agree with the fact that with the safety of the baby and the safety of the mother, we also have to think of the safety of the doctors and safety of ourselves, because if something goes wrong, there will be no much of stone unturned to abuse us physically as well as in the court of law. But please believe me and remember one thing, that if a lady has to be delivered vaginally, she will deliver vaginally. If it has to go for a cesarean section, she will go for a cesarean section. We do not need to get a bad name by trying to abuse them, by trying to abuse them physically, by verbally and telling things to them. The only thing that we need to do is monitor the fetal heart sound and see that everything is all right with the fetus. That's all. More than that, there's nothing more that is required for us to do. I had taken 20 minutes time from Anit. I think I have already finished 15 minutes. I may overshoot by 5 minutes if that is all right with all of you. Thank you. Okay. So I've got a note from Umayal ma'am, and I'm sure I can go ahead.
Please, go
Thank
ahead.
you so much. Yeah, so now talking about the best practices in postpartum. Close monitoring and surveillance during the first 6 hours of postpartum is a very important step. Please try and put a patient in a monitor bed if you can, to check for the pulse, the blood pressure, the vaginal bleeding, and the uterine hardness. The timing, every 15 minutes for 2 hours, every 30 minutes for 1 hour, and then every hour for 3 hours is normally how we should go ahead and check these patients. Now remember, I don't know how many of you use carbitocin over here, but I have been using carbitocin for the last 6 months, and initial 15 days, I was really scared with the fact that after giving carbitocin, the uterus got so hard, so tonically contracted, that I used to get a feeling that maybe the lady will go into amniotic fluid embolism or some bit of embolism because of the tonically contracted uterus. But it's been 6 months, and still now I haven't had a case where I had any complications like embolism. But again, I did not have any case of PPH as well, because the uterus got so hardly contracted. So I think that sort of a medication is quite useful. The only thing that I think prevents us from using it is the cost. But if you sit and analyze the cost, of oxytocin along with the IV drips, you will find out that the cost is equivalent, and it's not more than what 1 ampule of carbitocin will cost for your patient. And ultimately, whatever the cost is, I think the ultimate goal is safety of the patient, and that's why we all are here to update ourselves, to discuss these topics, because it's the patient's care that is of utmost importance to us. The position in labor and childbirth, allow freedom in position and movement throughout labor and childbirth. If there's one message that you want to take from this entire talk, this is the message that I would like to take. Give complete freedom to the woman. Let her do whatever she wants to do. Let her be in any comfortable position that she wants to. I'm sure there are a lot of women in this forum, and all of them, or at least most of them, would have experienced labor birth, and they know what I'm talking about, the sort of pain that a lady goes through. And we men by no way understand what sort of a pain a lady goes through, and that's why definitely a lady is so much more superior than what a man can go through in her life. I cannot even imagine every monthly bleeding, how a lady takes it, how a lady goes through it. And when with a small bit of cut, we cry of pain, we cry of so many things, we make up so much of fuss with it, but going through it years together is something that a lady really needs to salute it for. So give her that freedom, allow her that position, at least that much of freedom you should give her to go through that freedom of movement and position during her childbirth and labor. Encourage any non-supine position like side lying, squatting, hands and knees, semi-sitting and sitting, whatever she feels comfortable with. Support of women it goes a long way in facilitating or in encouraging her to deliver vaginally, gives women as much information and explanation as she desires, provide care in labor and childbirth at a level where women feel safe and confident, provide empathic support during labor and childbirth, facilitate good communication between caregivers, the woman and her companions. Continuous empathic and physical support is associated with shorter labor, less medication and epidural anesthesia, and fewer operative deliveries. Support from relatives improve labor outcome. Now again, support from relatives, if you find some time, if you gain the confidence of the lady, you will find some instances, you will find that a lady is not very comfortable with her, with few of the family members. Please try and make a convenient situation for her where she can be with people whom she is confident with, like her husband, like her parents, or whomever she feels that she can talk to, whomever she wants to stay with when she's in that sort of extreme pain. I think that much of comfort she desires, and she should be definitely given. Now, what are the harmful routines? Like I've already mentioned, use of enema, pubic shaving, lavage of the uterus after delivery, manual exploration of the uterus after delivery. Lavage of the uterus after delivery, I'm sure and I hope that you don't do it. Please don't do it, because that's a primary source of introduction into the perineum, introduction in the uterus, and subsequently into the peritoneal organs. Manual exploration of the uterus is not something that is implicated routinely. Please do not go and poke into the uterus, especially if you have done a successful VBAC, because that will be something that will not be nice for the patient during her childbirth. So the harmful routines, that's what is about the harmful routines. Now the other harmful practices that you can talk about are rectal examination, rectal examination, similar incidence of puberal infection, uncomfortable for women, routine use of X-ray pelvimetry, increases the incidence of childbirth leukemia. Position, routine use of supine position during labor, routine use of lithotomy position with or without stirrups during labor are the other things that we can talk about. So this gives a lot of comfort to the patient, and that has to be warranted and that has to be given to the patient. Harmful interventions could be administration of oxytocin at any time before delivery in such a way that the effect cannot be controlled, sustained, directed, bearing down efforts during the second stage of labor, massaging and stretching the perineum during the second stage of labor. No evidence, and believe me, it's harmful than causing any bit of harm. Fundal pressure during labor is absolute no-no. Please do not touch the fundus during delivery. The only place where you'll touch the mother's abdomen is when you have a case of shoulder dystocia, where you're giving the crystallis maneuver to push down the head so that the head can deliver. The other place where you'll do it is in a breech delivery, where you're giving suprapubic pressure for the head to stay flexed so that you can deliver. Please do not touch the abdomen other than trying to check the contraction and fetal heart rate. No fundal pressure, no other pressure that is warranted. The lady will deliver on her own without any much of complications for herself and for ourselves. Inappropriate practice, restriction of food and fluid during labor. Routine intravenous infusion in labor not required because it reduces the movement of the patient. Repeated or frequent vaginal examination, especially more than one caregiver. Remember, before doing a per vaginal examination, I still remember when I was in my Vellore days in CMC Vellore, when we used to do a per vaginal examination, especially in the night, we used to feel it's okay, I have no need of washing, we can just go and do a per vaginal examination. Once you get caught, you do not get labor room postings for 3 to 4 months is the punishment that you get when you do something of that sort. We had to wash every time, wear an apron, we had to go and wash our hands with soap till our elbows, wear sterile gloves, clean the peritoneum properly, and do a per vaginal examination only as per the Photogram warrants you. 4 hours in the second stage of labor, in the first stage of labor, every 2 hours in a primary in second stage of labor, and every hour in a multi in a second stage of labor. That is warranted, and that is only we'll have to go and do a per vaginal examination and not otherwise. Routinely moving laboring women to a different room at the onset of second stage, encouraging women to push when full dilatation or nearly full dilatation of cervix has been diagnosed before woman feels the urge to bear down, and that can be seen only with the fact that the anal sphincter has been dilated. Now coming to the labor care guide. So labor care guide was developed to improve every woman's experience of childbirth and to help ensure the health and well-being of women and their babies by facilitating the effective implementation of WHO intrapartum care recommendations. They are essential for good quality and evidence-based clinical care, expands the focus of positive childbirth experience for every woman and the baby. The WHO Labor Care Guide aims to guide the monitoring and documentation of the well-being of the woman and the child, guide the health personnel to offer supportive care, assist health personnel to promptly identify and address emerging labor complications, prevent unnecessary use of interventions in labor, and support audit and quality improvement of labor and its management. So when should the labor care guide be initiated? Documentation of labor care guide should be initiated when the woman enters the active phase of first phase of labor, 5 centimeter or more of cervical dilatation. So active phase of the first phase of labor, first stage of labor is 5 centimeter or more of dilatation. Second is when we say that the lady is actually in active labor. So 5 centimeter, remember, is when we say that, and we know that the lady is definitely into the labor and we can shift her into the labor room is when she is 6 centimeter and more, and not before that. Do not start your Photogram, do not start your WHO labor guide before that, because once you started, you have that apprehension, you want to do something for her, and in that doing something for her, you do repeated vaginal examination, and if she doesn't progress adequately, we shift her to the OR for a cesarean section, which is the ultimate goal, is to prevent that if it's not indicated. Once initiated, the labor care guide will support continuous monitoring through the first stage and the second stage of active labor, and also a bit of notes about the third stage of labor as well. The labor care guide is designed for the use of all levels of care in health facilities, although the plan of action will vary depending on the level of care. The use of labor care guide can facilitate early identification of potential complications. Hence, it should contribute to timely referrals when required. Now, there are 7 sections of the WHO Labor Care Guide. Section 1 talks about identifying information and labor characteristics at admission. Section 2 talks about supportive care. Section 3 about the care of the baby. Section 4 about the care of the woman. Section 5 about labor progress. Section 6 about medications. Section 7 about the shared decision making. These sections contain a list of labor observations which will benefit the lady in the long run. Now, section 1 talks about the woman's name, labor admission, and characteristics. And we have to also make a note of the parity, mode of labor onset, date of active labor diagnosis, date and time of rupture of membranes, and the risk factors. This section should be completed with the information obtained when active labor diagnosis is confirmed. Section 2, supportive care. Respectful maternity care is a fundamental right of the pregnant woman. It talks about supportive care, labor companionship, access to the pharmacological and non-pharmacological pain relief, oral fluid, and techniques to improve the woman's comfort. Now, if you see in the Section 2, you will see of the supportive care, you have companion, present or absent, pain relief, oral fluid, posture, and also we talk about the time and the hours from when we talk about the 5 centimeter and the time that has elapsed in hours and the time that it has gone through. Care of the baby, we need to look at the basal heart rate, we need to look at the fetal heart rate decelerations, look at the amniotic fluid, whether it's meconium stained or it's clear or it's blood stained, look at the fetal position, caput, and molding. So this will give us sort of a complete picture of what we are talking about, a complete picture of what the laboring mother is or the fetal situation in the labor is. Care of the woman is to facilitate the decision making. We have to look at the pulse, the blood pressure, the temperature, the urine output. The urine, along with the urine output, we'll also have to talk about the protein and the acetone, and we'll have to see whether there's any bit of proteinuria that is also developing, especially in case of hypertensive ladies, because it could be a setting of a preeclampsia that we could be missing otherwise. Labor progress, as has already been mentioned, this is a little similar to the Photogram, but you have different segments for the cervical dilatation and the descent, and you'll have to plot it with the X and an O in this case. Start with 5 centimeter, and as you can see over here, the descent is from 5 to 0. That is from a descent of 5 centimeter to the 0, and then from 0 to +5 is what we take, and we proceed accordingly. Medications aims to facilitate consistent recording of all types of medication using during labor by describing whether the woman is receiving oxytocin and its dose and whether other medication or IV fluid or doses are administered. So we look at oxytocin, we look at other medicines and the IV fluids in the section 6. And coming to the last section, that is a 7th section, shared decision making. That is, you make the assessment, you make a plan and you share it with the patient and the patient relatives, and that is through the first stage and through the second stage as well. So that will give us a frank idea of the enabling the shared decision between both of us. Now, WHO Labor Care Guide, it's a user manual that is present in the WHO website that had come in the year 2018, and it can be used through various NGOs, can be supplied in the labor rooms of the hospitals and otherwise for its accurate and proper use. Now, this is the favorite slide of mine, and I'm sure it's a favorite slide of most of you because you know that this presentation is going to come to an end. So to conclude my presentation, I would like to say that have a skilled attendant present, use labor care guide, restrict use of unnecessary interventions, use active management of third stage of labor, support women's choice for position during labor and childbirth, and provide continuous emotional and physical support to women throughout labor. And in addition to this, I would just like to add on one more point, that whatever you do, document, because ultimately documentation is the most important step, and only documentation can save us in case of any medical legal problems. Thank you so much for giving me this opportunity, and I would really like to thank Umayal ma'am, Chakravarti sir, Dr. Anit and Dr. Kritika and all for giving me this opportunity, and I would definitely love to be in Kanchipuram for the physical conference that you guys are doing. Thank you so much once again for the patient hearing.
Thank you, sir. Wonderful
Mute.
talk.
You are in mute, Kritika.
Nice talk, Priyanka.
Thank you so much, ma'am.
Need of the hour.
Thank you, ma'am.
Because the increasing cesarean sections is the much talked about topic. So
absolutely,
enhancing the labor process in a positive way will go a long way in we consultants trying to handle the crisis. Because cesarean section is becoming a crisis. And media loves to talk, the government tries to talk. And we obstetricians are the target.
Yes. So on the, I would like to also add on that media loves to talk, politicians wants to talk, everyone wants to talk about us in a negative way. And very sadly, our colleagues, our co-doctors also sometimes want to talk negatively about us, and that brings us totally down. That really is like digging onto your own graves is what we have come to a situation. And if we continue doing this, will definitely, the entire community of doctors will be in the grave in a few years from now. So thank you for the opportunity and thank you for your comment.
There are some questions in the box.
Yes, I would love to take them.
Kirti, you please take over that.
I can't see the questions.
The first
persons give permissions. I like to read out the. Shall I read the questions?
I'll read out if you want.
Yes.
Routine enema, if nodded while pushing, you want it be a messy, and at least right lateral episiotomy region shaving will be better. Will that be allowed? Although episiotomy is not recommended as a routine, do we give TX prior to cesarean or only carbitocin alone?
Ma'am, can I take one question in at a time, ma'am? If you can just ask one at a time. I can't see the questions here, so if you can just ask one at a time, that would be helpful.
Okay. Enema, can it be, won't it be a messy if it is not given?
Enema is not required. Why are we giving an enema? We are keeping up, if we are taking a patient for cesarean section, even for an emergency cesarean section, there is no role of enema at all. Normal delivery, there's no question of enema at all, ma'am, because the thing is, with enema, what it does is, there's bit of spurts of stool that comes out on and off, which contaminates the perineum. That is number one. Number two, that it does is the hot water that sometimes we usually tell our ayahs and all of them, and they are not so literate to do everything very coolly and very nicely. They were going to put in hot water into the anus and into the rectum, which will cause burns. And recently WHO has said a definite no to enema insertion into the anal canal, and also shaving. These two are a definite no for any sort of even for a cesarean section. They are saying that do not shave the perineum. It's not required.
If it is a 1 centimeter dilatation and the patient comes with a severe labor pain, and we have to wait for about 5 centimeters dilatation, it takes about nearly 12 to 16 hours for some primies. And meantime, it goes in for a meconium. And how do you, what is your experience regarding this?
Ma'am, if I understand the question, you're asking that in case of the first stage of labor, if the patient develops meconium, what do we do? Is that what you're asking me?
No. She's in only 1 centimeter dilatation, but she's got contractions, the 2 to 3 contractions, which goes on after. She's in the very early stages.
Yes.
According to the guidelines, we have to do a PV only after 4 to 6 hours.
Yes.
But with the severe contractions, how do you monitor her? What all you doing?
So monitoring is only by, as I have said, ma'am, only monitoring that we require to do is the fetal heart sound. So we have to keep a monitor of the fetal heart sound on. If the fetal heart sound is perfectly fine, there's nothing much that we need to worry of. We can repeat up, and it's the first stage 6 hours is in low risk cases. But in high risk cases, we can do it in 4 hours. So if we have a meconium stain amniotic fluid, we can repeat the pervaginal examination in 4 hours, and we can see the progress of labor. We do not need to do a repeated pervaginal examination. If the FHS is absolutely fine, then there's nothing to worry about. If the FSH is dipping, then of course you'll do a pervaginal examination to look for any cord that is entangled there. Or maybe if you have the habit of giving amnio infusion, you can give amnio infusion and try to dilute the meconium so that you can proceed with the vaginal delivery. But again, ma'am, to say all this, 1 centimeter dilatation with thick meconium, I think none of us will wait for a vaginal delivery, and it will be more of an indication for a cesarean section at that point of time itself.
No, thick meconium is only after doing ARM, we'll be knowing it. But
yeah, so that's what you said, ma'am. 1 centimeter meconium, you said, right? So I presume that it was after.
No, she said waiting for some more time, and then if it happens to be a meconium, how the patients generally come about asking. This PV should have been done earlier, and then the section should have been done earlier. If the baby goes in for a distress, that's what I think she said.
Ma'am, the baby distress thing is basically you're continuously monitoring the FHS. So at 1 centimeter dilatation, we of course we will proceed with our things only after giving the patient the choices. So you will give the patient the choice that you are 1 centimeter, you have meconium stain like a. Do you want to wait on, or you want to go for cesarean section? That point of time, if the point of the patient is we want to go for cesarean section, definitely, ma'am, a thick meconium at 1 centimeter or 2 centimeter, whatever it is, will be an indication. That is not something that is not indicated. But if the patient wants to wait on, we can monitor the FHS, we can give amnio infusion subsequently, we can dilute the meconium as much as possible, and then go in for our vaginal delivery. But repeat a PV after 4 hours, or if it's not indicated, if it's indicated, you can do earlier whenever it's warranted.
And then in second stage labor, after 5 centimeters, after 6 centimeters, you can shift it to second stage labor is a thing you're told. And after that, doing a ARM, how do you make the patient to mobilize or ask them to sitting position is different?
Ma'am, why do you want to do ARM? My question is, why do you want to do ARM?
6 centimeter dilatation to activate, to augment it.
No, ma'am. See, the thing is that if the labor is already on its own, if the patient is progressing already on its own, if there is no, because we know by partogram also alert line and action line, we had to do any step only when it had crossed the alert line. Even if it was for ARM, that was only after it had to cross the action line. We do not need to touch the patient or do anything before that. We do a PV after 4 hours. We see that the patient is in active stage of labor. Then after that 6 centimeter or whatever it is, and then it's not warranted, or even WHO or FIGO, none of us tell us to do a ARM. It's only spontaneous rupture of membrane that is what is warranted, and that is what all the guidelines talk about. But in case if you feel you want to do a rupture of membrane, you can sort of do it. I know our fingers itch whenever the finger is nicely dilated, is nicely effaced, it's getting 11:30 in the night, and you want to deliver and go to sleep. I know all these things do happen. We do go through it. But since we are talking this in the forum, we are talking about guidelines over here. We do not need to do an artificial rupture of membranes until and unless it is indicated. Wait only for spontaneous rupture of membranes. If it is not getting augmented on its own, if you feel that it's going towards the alert, towards the action line, then do ARM, and then you can subsequently see it accordingly. But starting a fluid from the first stage of labor is again not something that is warranted. So we do not need to put a syntotype from the beginning itself in case the patient is going to spontaneous labor herself.
Thank you. Thank you very much.
Any other questions, ma'am?
So better to admit the patient. It's better nowadays. For the past 1 or 2 years after this COVID, I have learned something, that admit the patient only with active labor pains. Because here in Tamil Nadu, even with one slight pain, the patients call up and they end up in the hospital, giving an obstetrician's distress. Every time you go see the patient, just by even palpating, 2 attenders or 5 attenders come out and saying, when are we going to deliver? So I have I'm teaching them how to monitor labor, and only with the active labor pains of more than 2 contractions lasting for 30 seconds, I then send them back. Ask them to come back with good labor pains. That's more better, I think so.
Absolutely. So it's best actually, ma'am, to admit the patient when it's in active stage of labor. But then again, as you said, but then again, sometimes we intend to admit them probably a little earlier and then see it subsequently. So whichever way. I see a question here from Dr. Chitra, and ma'am has asked about shaving and episiotomy. Ma'am, episiotomy and shaving both are not things that are routinely to be practiced. But then in case if you have, I understand your concern of probably suturing the episiotomy if there is perineal this thing, ma'am, do not shave. Trimming is still allowed, but shaving is something that is definitely not there. You can actually, if the patient has had antenatal with you, you can actually tell them to do it at home and come to your hospital. Do not try and do it in the hospital because that's not something that is very very hygienic or something that I can say. The next question from you is: do you give treatment
Tranexamic acid.
Tranexamic. Okay. Yeah. So, ma'am, in cesarean section, my routine practice is tranexamic acid is given to the fluid when we start 1 hour prior to the taking the patient for cesarean section, and I use carbitocin for the last 6 months with very good effect. Carbitocin previously had the contraindications of methergin, that is cardiac disease and hypertension. But in current day practice, there's an article that has been published in one of the journals, which also talk about that hypertension can be taken off from the list of conditions where carbitocin cannot be used, because in oxytocin, when we are giving oxytocin, we give it with some bit of fluid. That bit of fluid can lead to a little bit of overload in case of preeclampsia patients. So carbitocin does wonders in these patients, but there has been no study yet which talks about carbitocin in complex heart disease patients or in other heart disease patients. So that is something that maybe we have to wait for some more time. And there's another question from Dr. Chitra, ma'am, again, amnio infusion, how do you practice? Okay, so amnio infusion is by a K60 catheter, ma'am. So so ma'am does it regularly, she says. So what we routinely do is, ma'am, we have this K60 catheter. So when we do in your pervaginal examination, you make a space between the head and the cervix. You can put in the K60 catheter that does not get compressed between the head and the cervix. And then if you do not have any fetal decelerations at that point of time, you can just insert the catheter and leave it there. And you can just clamp it and leave it there at that point of time. Subsequently, if you see any decelerations, you can connect it with a lukewarm normal saline that can be connected at a rate, maybe the fluid bottle to go over 4 to 5 hours. So that the main thing of action, what it does is 2 things. One, in case of oligohydramnios, there's some bit of fluid that goes in and prevents the cord compression. Second, in case of meconium, it dilates the meconium. Even if the baby gulps down the meconium, it's dilated meconium that the baby is gulping down, reducing the complications subsequently, reducing the chances of fetal heart decelerations, and reducing the depression or the distress in the baby consequently in these cases.
I think, thank you so much, Doctor. We are just running short of time.
Yes, I've overshot the time. I'm really sorry for that, ma'am.
No problem, sir. No problem. Dr. Kritika, would you like to finish the session?
Yeah, that was a very good, very informative talk by both the speakers, Anit and Dr. Priyankur. Dr. Priyankur, he walked with me in the ramp in ACOG indoor. Yeah, so very talented doctors, both of them, and I wish them all good success in their future endeavors.
Thank you for the opportunity to all of you. Thank you so much for letting me be here. Thank you.
Okay. Thank you, Dr. Kritika and Dr. Bhuneshwari. And thank you, Dr. Anit, and thank you, Dr. Priyanka. We'll just move on to the next section of interesting case presentation, cream in the box. This will be chaired by Dr. Umayal, madam. Can you start, madam? Yeah, Dr. Umayal, madam, as I've told before, she's the director of Sri Kumaran Specialty Hospital and founder secretary of
enough. Already introduced.
Okay, thank you, ma'am.
Next you can introduce.
Yeah. Dr. R. Venkateshwari, madam. She's a professor in Government of Changalpet Medical College. She's worked as RMO at prestigious Gandhigram. Yeah. For Gandhigram Institute for Women and Children of Dindigul district in Tamil Nadu. She's worked as HOD of OBG in GVMSH from 2015 to 18. And present, she is HOD for Chengalpet Medical College, and she was superintendent for RSRM between February to December 2021. She's got various awards at Best Semonic Performance State Award in 2016 from the Government Villupuram Medical College, and Best Doctor Award in 2018, and Best Doctor Award in 2020 recently by RSRM. And the during the COVID, she has been one of the best performance been done by the given award for District Collector. Over to you, Madam. And the case will be presented by Dr. Karkurili. She's from Chengalpet Medical College. She's a PG, and she has done her MBBS from Tanjavur Medical College, and currently she's doing her obstetric gynecology in Chengalpet Medical College.
Good evening. Welcome, Dr. Karkurili. Chengalpet, I'm an alumni of Chengalpet. My undergraduation was from the college. It's a great place to learn. When we were doing our UG, there were only 50 students. But now I think there are 150 students. And the PG, when we were doing, there was no PG. But nowadays, there are a lot of postgraduates there. And they are highly trained in the basics. Always obstetrics and gynecology is, the basic is most important. So a student who is getting graduated from Chengalpet Medical College will be very good in the basics. And so I welcome you, Dr. Karkurili, to present your interesting case, and then we will discuss about it. Venkateshwar, Madam Antangla.
Yeah, I'm here, Madam.
Madam, you can welcome, Madam, please. You can give your introduction.
Thank you, Madam. I thank the President, Dr. Chakravarti sir, and Umayal Madam on behalf of Chengalpet Medical College for giving the opportunity to our student. Very happy to join Kanjipuram Obstetric Gynecology Society. Thank you, Madam. Over to Karkurili, we will discuss with.
Good evening to all the respected professors and doctors. I am Dr. Karkurili, postgraduate from Chengalpet Medical College.
Ma'am, could you please make it full screen?
Thank you. Yeah, full screen. Good.
Yes. Good evening to all the respected professors and doctors. I am Dr. Karkurili, postgraduate from Chengalpet Medical College. I take immense pleasure in thanking the President and members of KOGS for giving me this opportunity. Also, my beloved HOD, Dr. Venkateshwari ma'am, for guiding me through this presentation. My topic is regarding a case report of appendicular mass perforation with intrauterine pregnancy. So, my patient is a 38-year-old female, para 1 live 1, previous normal delivery, LMP 3322, with who came with complaints of severe abdominal pain for 1 day and complaints of vomiting 2 to 3 episodes, and no history of fever was present. A history of amenorrhea for 48 days was there, and on admission, patient was moderately built, not anemic, not ectric. Patient had tachycardia and her BP was normal. On abdominal examination, patient had tenderness all over the lumbar, iliac, hypogastrium, with including the umbilical region. Body and rigidity was present. On vaginal examination, cervix pointing downwards, uterus was anteverted, 6 to 8 week size, os closed, formus is free, formicial tenderness was present, no bleeding was there. PT tested positive, and in labor ward ultrasound, it revealed a gestational sac of 5 week size. Yolk sac was seen, no fetal poles was seen, minimal free fluid in the pouch of Douglas was present, no adnexal mass was seen.
Some connectivity problem?
Your voice is not audible, ma'am.
Screen is also frozen. Karkurili?
No. Something to do with the connectivity, I think.
Yeah. Madam?
Ask her to reconnect again. Vijay? Ask her to reconnect. Okay. Seems to be a very interesting case. Differential diagnosis.
No, I'm not able to connect her.
You have the slides?
Slides call பண்ணிட்டு
Or we will start introducing the new members. வந்தோனே உள்ள விடலாமா?
மேடம் வச்சிருக்காங்களா? ப்ரொஃபசர் மேடம் வச்சிருக்காங்களா ஸ்லைட்ஸ்? மேடம்?
Venkateshwari madam?
You've got slides, madam?
Venkateshwari ma'am.
Madam is there on the line.
Unmute பண்ணுங்க அவங்கள. Host, please unmute Venkateshwari madam.
Yes ma'am, I'm trying, but she's not unmuting.
You can unmute from your end.
இப்போ ஒரு டாக்டர் ஜாயின் பண்ணிருக்காங்க. Let us see whether she is or not. Doctor?
The Venkateshwari madam is should be unmuted.
Karkulali? Dr. Karkulali?
Yes, sir. Sorry for the
நெட் கனெக்ட் இருந்துச்சுன்னா PowerPoint வேணா ஷேர் பண்ணுங்க. இங்க எங்க லேப்டாப்ல நாங்க ஷேர் பண்றோம்.
Yes, sir.
கனெக்ட் ஆயிட்டு இருக்கா? And start sharing it. தெரியுதா?
தெரியுது. Can see.
தெரியுது. See.
Okay. Can you start present? Just tell me next slide. Okay. Present பண்றீங்களா?
On her abdominal examination, tenderness was present all over the lumbar, iliac, hypogastrium, and umbilical region, along with guarding and rigidity. For vaginal examination, cervix was pointing downwards, anterotor, uterus 6 to 8 weeks size, os closed, fornices free, fornicial tenderness was present, no bleeding was there. Her UPT tested positive, and labor ward ultrasound revealed gestational sac of size 5 weeks and yolk sac was seen. No fetal holes was seen. Minimal free fluid in the POD. No adnexal mass. Vaginal probe tenderness was present. So we proceeded with cultosynthesis, which to obtain a purulent aspirate from the POD. Lab investigations reveal elevated total count. So at this point of time, we had a differential diagnosis of heterotopic pregnancy and ruptured corpus luteal cyst. Next slide, sir. Experts ultrasonogram was done, which was showing gestational sac and fat standing in the pelvic fossa, minimal free fluid in the pelvic cavity. So we needed surgeon of suggested bleed treatment, which the findings were fat stranding, free fluid with collection in the pelvis around the uterus, gestational sac measuring 15 cross 16 mm. So, in view of persistent pain in the lower abdomen, increasing guarding and rigidity, increasing pulse rate, free fluid in the pelvic cavity, emergency laparotomy was proceeded. So, during the surgery, intraperitoneal trunk was 50 ml was drained from the pelvis, and the appendix was, next slide, sir. The appendix was found to be gangrenous with perforation. Uterus was just bulky, and bilateral tubes and ovaries were normal. Bowel loops were healthy. So saline wash was given, appendectomy was done, drain kept intraperitoneally. Hence, the final diagnosis is a case of perforated gangrenous appendicular abscess with peritonitis with intrauterine gestational sac. So the most common non-obstetric indication for surgery during pregnancy is appendicitis. The occurrence is 1 in 1,500 pregnancies. Symptoms are more common in non-pregnant females than pregnant females, whereas the rupture of appendix is more common in pregnant females than the non-pregnant. The distribution is around 30% in the first trimester, 40% in the second trimester, 30% in the third trimester, labor and puerperium. Delay in diagnosis leads to delay in the treatment, which causes increased risk of fetal loss and gangrenous appendicitis, appendicular mass perforation, and peritonitis, which in turn increases the risk of maternal morbidity and mortality. The following are the confounders which delays the diagnosis, which are like vomiting and abdominal pain are the most common symptoms in pregnancy. Uterine contractions can obscure appendicitis. Mild leukocytosis and increased ESR are common in both. If more importance is given to these confounders, it leads to more number of laparotomies, whereas if less importance was given, it leads to delay in the diagnosis. During pregnancy, there is a normal upward displacement of the appendix, which corresponds to McBurney's point at 12 weeks of gestation, right iliac crest at 24 weeks of gestation, and the appendix overlies the kidneys at term. Considering all these confounders, it is prudent to suspect acute appendicitis in any pregnant women with right-sided abdominal pain, regardless of the location. So it is the suspicion and not the constellation of all classical signs which indicates the need for surgical intervention in pregnancy. The removal of appendix is justified. Normal appendix is justified to avoid the tragedies following the expectant management. Delayed operative interference can lead to high fetal loss, occasionally maternal death. Risk of perforation is doubled if the diagnosis is delayed by 24 hours from the onset of signs and symptoms. So, a few common signs and symptoms which are elicited include localization of tenderness to the right lower abdomen, lower quadrant. Most important and the only sign is persistent pain at or near the McBurney's point. Bryan's sign is nothing but pain on moving the gravid uterus to the right. Periappendiceal inflammation or peritonitis can also be found. So the diagnosis is mainly appendiceal displacement predisposes the woman to rapid development of peritoneal infection since omentum is not nearby to contain the infection. The other modalities which helps in the diagnosis are USG and MRI. In USG, it helps in ruling out ectopic pregnancy, torsion ovarian cyst, and the appendicitis. MRI The finding which is present in MRI is enlarged fluid-filled appendix more than 7 mm in diameter. The best diagnostic modality is proper history and careful clinical examination. The treatment which is when we come to the diagnosis of appendix, the treatment for at all stages of pregnancy is immediate appendicectomy. During the surgery, the key point is gentleness, and McBurney's muscle splitting incision is made. Unhurried maneuvers should be performed. Handling of the uterus should be avoided. Spread of infection should be prevented. If pus was present, just in this case, peritoneal lavage has to be done. In few cases where the cecal wall is edematous, inversion of stump should be omitted. Drain should be kept only if the stump is perforated. If there is no pus, no drain is needed.
That's
Thank
it.
That was a very good presentation, Karpulali. I think you would have been surprised when you did the needling. No? You were expecting blood and
Yes, we were expecting blood and
yeah,
it was fast.
so that was a very interesting one. And ultimately, the simple diagnostic procedure made you finish the diagnosis, because most of us were expecting ectopic when you started the talk. And then appendix process and you have managed it well. So
yes, madam, this patient, sorry to interrupt, madam.
Venkateshwari madam, neenga solunga.
Yeah, yes, madam. Acute abdomen is a real challenge for the obstetrician, as everyone knows. It's a real challenge for the duty doctor when they are encountering a pregnant woman coming and also a non-pregnant woman coming to our OPD. The thing is, we have to keep in mind, I used to tell our obstetricians should think like a surgeon while approach a woman with acute abdomen. And the surgeon should think like an obstetrician while approach a woman, if any pregnant woman, going to them for acute abdomen. So that we will not miss any patient. We will not miss any surgical problem. As you all very well know, the confounders as this girl presented in this case report, the confusions usually is the nausea and vomiting of pregnancy and the physiological changes which occurs during pregnancy in the anatomical and the physiological changes which occurs during pregnancy of some of the important organs inside the abdomen, like appendix, cholecystitis like gallbladder, and other bowel. So we have to think like a surgeon while examining a pregnant woman for an acute abdomen. That's what has happened. They asked for an opinion. I said, you please do an ultrasound. Dr. Shobana did an ultrasound and said, madam, definitely there is an intrauterine sac is there. I said, why not it could be a heterotopic pregnancy with a ruptured ectopic one. She said, no, madam, there is nothing else in the adnexa. And I said, if it is not, there is nothing in the adnexa, you are very definite about the intrauterine pregnancy. Look for the other options, look at the abdomen, palpate the abdomen and look for the thing. She said, rightly, of course, tenderness was there. The next day, after 4 hours, then immediately I said, ask the surgeon to come and see the case. They saw the case. Within 2 hours, they have, I think, 4 hours at the admission time, and the interval was 4 hours. They operated the case, and it was a pus in the appendix, and it was a appendicular abscess. So for the abnormal thing and for interesting case presentation, we are presenting from Chengalpattu, and it will be useful, I think, for the clinicians. And one thing I want to stress on this, usually as obstetrician, we usually worried about subjecting the woman for X-ray, the diagnostic procedures. We should not penalize them. I used to, our professors used to say, don't penalize any woman for being pregnant. We have to give them all the advantages to undergo the modalities of investigation modalities like X-ray, ultrasound, CT, helical CT, in this case, helical CT if possible, MRI, all those investigations, because all these are not having much exposure. The minimal maximal, even the fetal problem or fetal abnormality or fetal involvement due to radiology, exposure to radiology is 5 rad. Now, none of our investigations is going to give 5 rad exposure, like abdominal X-ray. And also we can use the abdominal shield so that patient may not have that exposure. And we have to, of course, we have to get informed consent. And laparoscopy, the liberal use of laparoscopy nowadays in recent advance, we have to use, we can use, if the clinician is very much experienced, they can use laparoscopy in patients presenting with acute abdomen of pregnancy, like acute appendicitis and acute cholecystitis, the most common two procedures, surgical procedures for obstetric patients. That is the use of laparoscopy. All these investigations can be definitely useful so that we need not worry about acute abdomen in pregnancy. Thank you for giving the opportunity, madam.
Yeah, actually, like a lot of torsion ovary also with the pregnancy we are encountering when we have pain abdomen. And so laparoscopy is a very useful tool. And with laparoscopy and minimal invasion, we can actually treat these patients in a much more efficient
manner. And they can continue the pregnancy till their delivery.
Yeah.
So we are doing a lot of laparoscopic ovarian cystectomy also, torsion ovary, emergency laparoscopic surgeries.
Thank you for madam, and thank you,
madam.
Really. Yeah, that was really wonderful.
Thank you so much.
I have 2 things to say, ma'am. Can I say?
Yeah. Say.
Yes.
When was this done, ma'am? How is the fetus now?
Fetus patient, this case, she has a para 2, life 2. Actually, P1, L1, LCV was 17 years. The woman was 39 years, and it was an accidental pregnancy. She came with a persistent, severe lower abdominal pain. It was a very early pregnancy, so they didn't want to continue the pregnancy. And we also gave them the opinion to, they were suction curettage, termination of pregnancy. Simultaneously, they did terminate the pregnancy.
Okay. Actually, during my PG also, I have seen one case of a term pregnancy with appendicitis, ma'am. Our initial diagnosis was an abruptia placenta, actually, because it was a term uterus. After delivering the baby and looking in the routine posterior check, we found a lot of pus and abscess, and then on-call surgeon was called. So it can present in that way also. In term case, our initial suspect would be an abruptia or an placenta. That point I just wanted.
And it is our duty to teach our students that appendix, normally the normal position is cecal, can be retrocecal, and once the rotation of counterclockwise rotation of the appendix up to the right iliac fossa. So any patient presenting with right hypochondrial pain, right lower abdominal pain, in a pregnant woman, we have to think other than the PAH patient presenting with hypochondrial pain due to hematoma, subhepatic region hematoma, and due to PAH, severe PAH. We should also think this pneumonitis. Also, we have to teach the non-obstetric reasons for acute abdomen. Nowadays, it is not. We are not able to find these kind of cases. Very few cases are coming. This is also a 4th case for me in my experience. 3 cases we have during second trimester 1 and the first trimester during MD. And this is the 3rd case. This was very properly managed by our team.
Yeah, I had a 28-week-old pregnant woman with appendicitis. We had diagnosed it, and we went for a laparoscopy because the patient insisted a laparoscopy. So we went inside. We took the incision on that left point. I don't know which point that's. Palmer's point. We went in, yeah. What happened was, like when we put the trocar itself, it was Dr. Sundaram. He used to come to my place to do the surgery. The trocar went straight into the uterus, and Liker was coming out. And then we did. We just kept that trocar there. We didn't remove it, and then we went to another point. We finished he's very bold actually. We did the appendicectomy, and then we removed the thing, and we observed there was actually the wound got sealed by itself. And then we kept her for observation for 3-4 days, and then we discharged her. And now the child is 17 years.
Oh.
She continued the pregnancy and it was a repeat LSCS. So we delivered her. So that 28 weeks, it was a shock to see water pouring out of the trocar. So,
the Adler's sign, we used to teach our students, Adler's sign and the Bryan's sign. Shifting the uterus to the same position will produce pain. All this will be useful to the students.
That was the beginning of laparoscopy. And patients really, that she was a very educated patient. She was insisting. Husband was insisting more. So we tried and we did it in lap only. We didn't open. So that was a good thing. Now, she is patient, but I went and discussed with the husband everything in detail. Since he was educated, he accepted. And so even now, he's one of my best friends. And he's now a friend, now more a family friend. He came for my son's wedding and all that. And the Tenkasi and all he gave. So I think we will close this. Madam, shall we close this session?
Yes, madam. Chakravarti sir is there, madam.
Chakravarti sir?
Madam is not in connection. Sir.
Sir, second. Sir, I think log out panitarna nikiren.
Okay.
Chitra, you go ahead with introducing the new members.
Thank you, ma'am. Venkateshwari ma'am. It was a wonderful explanation. Lot of pearls of knowledge you gave, especially that surgeons should think as a gynecologist and gynecologists should think like a surgeon, and various explanation about a basic anatomy was really useful. Learned a lot today. Thank you, ma'am.
And good information you have told that wide use of X-ray, CT. I think we have to see the patient rather than the radiation. That is also important carry-on message which you have given, madam. Thank you very much.
Thank you. Thank you.
Okay. Thank you, all of you, madam. Thank you, Jamayal, madam. Thank you, Karpurli, for your excellent presentation. Thank you, madam. Venkateshwari, madam. Shall we introduce our new members who are very actively waiting here?
Yeah, we are all waiting to see the new members because we have not met most of them personally. So waiting. Please introduce.
Yeah. First, Dr. Lakshmi Ravindra, will you mute yourself? Will you unmute yourself on the video? Can you open it? Dr.
Yes, ma'am. Good evening.
Yeah. It's better you introduce yourself. That will be better.
I'm Dr. Lakshmi Ravindran and I'm from Adyar. I finished my undergraduation as well as post-graduation from Ramchandra Medical College. And I have my own hospital along with my mother and my sister in Adyar. So my basic interests are both in high-risk obstetrics as well as laparoscopy and infertility, ma'am. So I'm very happy to join your society as of now. So looking forward to having more connections with you.
Lakshmi is a very cheerful person. Always smiles and smiles and smiles. She has a lovely daughter. And she will be a very good addition to our society. We are really happy you're here with us, Lakshmi.
Thank you so much, ma'am.
We would like you to be an active participant. Adyar romba pakkam. So naanga offline vachalu neenga varanum meetings la vanda.
Kattayam varam, ma'am. Definitely.
Okay.
Ramchandra mudichirkinga. So ingoda junior. Which batch did you finish?
Ma'am, 2007 I finished my MS, ma'am.
Okay. Anyway, nice entering to our KOGS society. We welcome you.
Thank you, ma'am.
Anything you want to tell anymore?
Ma'am, further on, when we meet, we'll talk, ma'am.
Yeah, sure.
Can we stop the live?